We are joining from different time zones, and it will be prejudice if I say good evening. So I'll just tell hello to the speaker for today, Dr. Nagamani Narayana, and I will be telling hello to my colleagues, the principal of JSS Dental College and Hospital, Dr. Ravindra, and the director academics of JSS Academy of Higher Education and Research, Dr. Kushalappa sir, our head of the department of oral pathology and microbiology of JSS Dental College and Hospital, Dr. Usha Hegde, and the champ of today, who has been working behind the screens to connect us all, Dr. Sumukh Bharadwaj, who is an intern from Dental College, but quite dynamic and very active. So he's been the power behind all the webinars that we are conducting all these time. So without much ado and not wasting and taking away much of the time, as many participants are waiting for listening about the Salivomics, I request Dr. Ravindra, Principal of JSS Dental College and Hospital, to formally start this session with his welcome speech, following which we will have a talk from our Director Academics, and then we will go on to listening about Salivomics from our resource person. Dr. Ravindra, sir, please.
Thank you, Dr. Prashant. Good evening to everyone seeking the blessings of His Holiness. It gives me an immense pleasure to welcome Dr. Nagamani Narayan, Associate Professor, Department of Oral Biology, UNMC College of Dentistry, USA. She is also an alumni of Government Dental College, Bangalore. I welcome you, madam. I welcome Dr. Kushalappa. Dr. Kushalappa, Director, Research, Director Academics, JSS Academy of Higher Education and Research, who is always support and encourages us in all our endeavors. I welcome you, sir.
Thank you.
I welcome all our panelists and participants to this webinar. I would also like to express my sincere thanks to Dr. Patan Shetty for helping us in organizing this webinar. I once again welcome each and everyone to this webinar. Have a nice evening. Thank you.
Thank you so much, sir. With your permission, I request Dr. Kushalappa to have his opening remarks, following which the stage will be for Dr. Nagamani Narayana for talking about the topic on Salivomics. Dr. Kushalappa, sir, please have.
Thank you. First of all, I would like to invoke the blessings of His Holiness and thank the organizers, JSS Dental College and Hospital, Mysuru, specifically the principal, my good friend, Dr. Ravindra, and the Department of Oral Pathology for inviting me to this webinar on Salivomics. I appreciate the initiative taken by Dr. Usha Hegde, Dr. Priyanka Nitin, and the Department of Oral Pathology to organize this webinar and continue the motto of JSS Academy of Higher Education and Research, which says learning never stops at JSS. I also would like to commend the role played behind the scenes by Dr. Sumukh. I'm very happy that an intern is taking so much interest. Sumukh, I really applaud your efforts.
Thank you.
I'm also pleased to hear that a person of the caliber of Dr. Nagamani Narayana from University of Nebraska Medical Center is delivering the main talk today, and Dr. Jaishankar, Dr. Prashant, and Dr. Usha Hegde, along with Dr. Priyanka, will be participating as panelists and also be a part of this program. Salivomics is an interesting subject, and I just was wondering where, in India, the only thing we think of is spitting out. So we never think of the importance. And here, the importance of saliva cannot be measured enough. It helps in maintaining the alkalinity of the oral cavity and also the cleanliness. And further, there is enough evidence to track early cancer cells and a host of immunoglobulins which all adds up to its importance in diagnosis, prognosis, and maintenance of health and identifying disease. Especially in COVID times, we know that the diagnosis is made from the oral mucosa. And alternatively, being a dermatologist, I know the importance of the transmission of especially one type of lepromatous leprosy through saliva, and mainly the diseases like tuberculosis, to just mention a few, and even the common cold, and now, of course, the COVID, the virus. I can go on and on about the importance of saliva, and I've been reading about it for the whole afternoon, brushing up my knowledge. But then, with a galaxy of reputed speakers here to enlighten you all, I bow out with thanks again to the organizers and for organizing a webinar at this time, where whenever the webinars are organized, they have a big role to play in continuing education. And especially, I always tell the Department of Oral Pathology, there's so much of knowledge, there's so much of knowledge which you can give to everyone from pathology. And I'm so happy that you have taken this initiative, and may this be the start of many, many more webinars from you and the dental college in the hospital. Thank you very much, and over to you.
I will navigate through now, and I will let the platform on to Dr. Nagamani Narayana for her enriching talk on Salivomics.
Thank you so much for giving me the opportunity to share on Salivomics. And I work at the UNMC College of Dentistry, and with COVID and with Ebola, UNMC has come to the forefront, and they are working really hard on COVID at this time. So you hear a lot of doctors from UNMC Medical School talking at different platforms. But anyway, we will talk about Salivomics today. Oops. I just wanted to share that I have no conflicts of interest to share. And then the main objective of this particular presentation is to discuss what is normal saliva, how it is useful in what is Salivomics and how is it helpful. And we'll also talk about dry mouth and xerostomia and sialuria. So these are the few topics which I'm going to talk about. And if you have any questions, please stop me and ask me questions anytime. It is an informal presentation, so don't worry about stopping me. And I just wanted to remind everybody about the normal Asinar units, because I'm a pathologist as well as an oral medicine specialist. So I wanted to bring out my pathology here and to show you that these are the normal Asinar cells. These are the serous units, and this is the mucin unit, and this is a combination with demilunes. And the normal daily secretion of saliva varies from 0.5 to 1.5 liters every day. And it varies based on different time zones, and different environmental reasons, or any body changes or health disease status. So the saliva has been actually in my second year of dentistry, when I started doing clinical dentistry, I looked at saliva was a problem for me. When I opened the mouth of a patient and there was so much saliva, I thought, oh my God, why did I join dentistry? Because I couldn't deal with saliva. But now, I see a lot of patients who have no saliva, and I see the problems. So saliva is an important unit in the oral cavity, and it's a kind of a mirror of oral health and general health. And our dean, Dr. used to tell us that mouth is a mirror of oral health, and it is you are as a dentist, you are the captain of the ship. That's what he would tell us. I was laughing in my mind at that time, but now I think there is some meaning to that. And I was involved in doing some meta-analysis on saliva for the World Health Program. And this was a paper which we published on the formation of saliva. And here you can see the sympathetic and the parasympathetic nerves stimulating the acinar units, and then the myoepithelial cells and the acinar units produce saliva, and they are the saliva which is produced here is altered when it goes through the ductal system. So the ductal cells play a very important role in altering the saliva. So you can see that it has electrolytes and lot of proteins and everything in the saliva. So to make it better, you have another chart here to show the parasympathetic nerves, how they stimulate the M3 and the M1 muscarinic receptors and result in producing fluids. And norepinephrine or the alpha-2 adrenergic receptors will result in protein production. So proteins and fluids all help to maintain the oral cavity in a normal homeostatic fashion. And the contents, 99% of saliva is water, while 0.3% contains protein, and the inorganic and the organic substances form about 0.2%. So here there are all these different things. These are all lysozymes, lactoferrins, cystatins, and these play an important role in containing the microbial growth in the oral cavity. They are antimicrobial, and they are helpful for reducing the amount of proteins and reducing the number of viruses and even the fungi, the candida, which is responsible for a lot of problems in the oral cavity. So we'll talk about the function of saliva. We all know it helps in moistening and lubrication, taste and smell, digestion, and digestion probably, basically it is making it like the chewing and the forming of a bolus which is covered by mucin helps in swallowing, and problems with Sjögren's can have problems swallowing for swallowing, and taste and smell. Taste is affected in Sjögren because the taste is possible because saliva helps in distribution of the oral, when we are chewing the food and it is distributed around, and it works on the taste buds and helps in feeling the taste. And there are a lot of different taste buds and different receptors responsible. If we start talking about it, it will be a seminar by itself. So I'm not going to deal too much on that. Protection of the oral mucosa is an important role. It prevents any trauma and trauma from the normal chewing and things like that. And tooth, as dentists, we are all looking at the teeth, and it helps in protecting the teeth by forming the acquired pellicle. So the pellicle is important, and sometimes the saliva actually coats the oral mucosa, and it forms a very thin coat of mucin, and that MUC4 and MUC5 and MUC7 is helpful for coating the saliva, coating the oral mucosa, and it helps in protecting the oral mucosa from damage. So these are some functions of saliva, and you can talk about it in detail for a long time. Anyway, so we will go into Salivomics, and there is a lot of work that is being done on Salivomics because saliva is used as a all the different proteins and the enzymes and interleukins, cytokines that are present in the saliva can be used to diagnose and monitor patients. And collection of saliva is very easy, and you just have to ask them to spit, and you collect it, and storing is easy, and saliva does not clot. So there are all these good things about saliva. So that's why it is such an important tool in our diagnostic toolkit. So the alphabets that are available in saliva proteins, so then you can call it proteomics, or if you look at the messenger RNAs, then you call it transcriptomics or genomics, and microRNA omics, and microbes are measured and looked at, that is the microbiomics, and then metabolic compounds can be measured, then this is the metabolomics. So you can have different things that you're going to measure, and they all have they play a role in addressing disease recognition and prognosis. So now there has been some work done in oncology. So I'll start with oral squamous cell carcinoma first. And they have found tumor markers like CYFRA21-1, tissue polypeptide antigen, and then CA125P53, cyclin D1, Ki67, they are all elevated. Inflammatory proteins, MMP2, MMP9, and TNF-alpha are also elevated. So they have also seen proteins which have increased in number. So catalase enzyme is again increased. So they've said the particular study, all the studies have been done from Wong et al. From Los Angeles, and they have said sensitivity of 90% and specificity of 83% is being shown. So that is a pretty good change initially now. RNA biomarkers, all these are increased, but the sensitivity and the specificity is 91%. So that's a good thing, but really speaking, in oral squamous cell carcinoma, it is probably not so important to measure, in my opinion, it is not so much to measure the saliva for all these proteins to diagnose squamous cell carcinoma, because you can look into the mouth and see there is a growth and ulcer and non-healing ulcer and things like that, which are easily visible into the oral cavity. So the main point of using the saliva would be to identify pre-malignant diseases like leukoplakia or even submucous fibrosis. So in India, there are a lot of studies have been done on saliva from Indian subcontinent. So maybe they should work and look at saliva in submucous fibrosis, because there is nothing done on that particular disease. And that is a pretty nasty disease, and people chewing areca nut is causing the submucous fibrosis. Coming to lung cancer, they have said the haptoglobulin, calprotein, protectin, and zinc A2 glycoproteins are increased, and they have high sensitivity and specificity. But all these studies, they don't tell you when exactly they did the particular test. Was it pre-lung symptoms, or was it pre-radiographic identification, or pre-biopsy report? So we really don't know. There has to be better studies done to identify the use of saliva for diagnosing all these conditions. So they have said in the breast and ovarian cancers that CA15-3 is increased in breast, and while ovarian cancer has CA125 levels which are increased. And pancreatic cancer is a very bad cancer to have, and usually you see the RNA biomarkers will help to identify the pancreatic cancer. But if it can identify this early enough, that will be helpful. And EGFR, epidermal growth factor receptors, are also elevated in pancreatic cancer. So there are studies which are showing that they are increased, but what is the relative use in diagnosing these conditions, and how are they managing patients with this particular information is still debatable. Coming to autoimmune diseases, saliva has been used to diagnose Sjögren syndrome. Sjögren syndrome is a difficult disease to diagnose because it is like an solar eclipse, because everything has to line up together. It is not very easy. Sometimes patients come in with a diagnosis of Sjögren syndrome, but their antibodies are negative. So, it takes a long time to make a definitive diagnosis of Sjögren syndrome. They may be having something else. So they say the important thing is there is a decreased flow of saliva. So that is very clear. Everybody is okay with that, and everybody confirms that. But the salivary interleukins, IL-2, IL-6, and other protein biomarkers like cathepsin D, alpha enolase, beta-2 microglobulin, all these are increased. They are all, the exact mechanism, how they work in Sjögren syndrome is not really clear. So these are some of the inflammatory markers, protein markers, RNA biomarkers. All these are changing in Sjögren syndrome. In celiac disease, again, everybody says they have celiac disease. If they have diarrhea, then they have celiac disease. So there is decreased flow rate, and the buffering capacity of saliva is reduced. Usually, saliva has a pH of 6.8 to 7. So it is kind of trying towards the alkalinity, but mostly neutral pH. So that helps in keeping the oral mucosa intact. And celiac disease also shows increase in PGE2, that is the prostaglandin E2, which is again an inflammatory marker. Decreased activity of the protease and epidermal growth factor and IgA and anti-tissue transglutaminase could be present as well. So the thing is, all these things have been seen, but real change, why is it changing? And nobody is talking about it. None of the articles shed light to that particular aspect. Then there are multiple studies showing the cortisol levels in anxiety disorders, and they've done studies in dental school students, dental students in the first year compared to the senior year, how their anxiety levels are different, how the cortisol level changes, and even in Cushing's syndrome, cortisol level is increased. And it is also, they've also done studies on estradiol and testosterone because it has shown changes in adrenal and testicular tumors, hirsutism, and menstrual disorders. You can have even prostaglandin changes have been noted. In diabetes, there is increase in myeloperoxidase and IgA, again showing the inflammatory component. In cardiology, they've said in myocardial infarction, patients will have a raised C-reactive protein, myoglobulin, and myeloperoxidase along with salivary alpha amylase. And they have also shown alpha-2 HS glycoprotein has been decreased. And they did say that troponin and levels are not really definite in myocardial infarction. They may help myogenin and things like that may help, but may not be a different, may not be a significant change. In nephrology, people have shown creatinine levels are changed. They have increased in chronic renal failure. So the important thing is the COVID-19 now, infectious diseases. They have shown hepatitis level, A, B, and C has shown viral proteins. In COVID-19, we have seen viral proteins being elevated. Rutgers was the first university in the first, actually, initially in end of March, they said saliva can be used for COVID-19 testing, and it is it's a good test. But that test got approved by the FDA, and they were measuring the viral particles just like by using the RT-PCR technique. And but I don't know, there were all these tests that are available, but all the tests that have been described for COVID-19 have a problem with sensitivity and specificity. So I don't know whether there are more tests, more studies on the COVID-19 with saliva, except a study done by Rutgers showed that they were checking the patients who had the nasopharyngeal swabs and saliva, and there was agreement in all the cases. But probably COVID-19 on saliva should be, more results will come out at a later time, probably when they do studies on every patient who has had the testing, if they have done saliva testing. Saliva is easier to do in COVID-19 because you don't have to go very close to the patient, and they can spit into the tubes and send the tubes to Rutgers, and apparently Rutgers claims that they can give the result in 48 hours. But everybody has said that for most of the testing, but then the testing does take a long time now. So we have to take it with a pinch or bag of salt on COVID-19, how useful it is in saliva, whether it is really elevated, how, then. And another important part is COVID-19 gets into the tissue through the ACE inhibitors, ACE2 inhibitors, or the receptors which are present. And these receptors are more on the salivary glands and on the minor salivary glands. So people are saying that COVID-19 resides in the saliva and in the salivary glands, and may be responsible for patients showing asymptomatic COVID-19. So I don't know whether there is some protective mechanism. So if the COVID-19 can stay in the salivary glands and not really cause a disease, but make the patient asymptomatic, so there may be something good. We don't know. More work needs to be done on that. But COVID-19 attaches itself to tissue through the ACE2 receptors. In Alzheimer's disease, elevated phosphorylated and total tau proteins and lactoferrin and acetylcholinesterases have been found to be elevated. So again, we have to figure out whether it happens before the Alzheimer's disease affects the patient or it is afterwards. So there is no definite relationship mentioned in any of the articles that I read throughout this session. Then in periodontics plays an important role in the oral cavity, and they've shown increase in the inflammatory mediators. That is pretty noteworthy. And when there is inflammation, there are inflammatory mediators, and connective tissue breakdown products could be increased as well. MMP9 and osteocalcin and proteoglycan and fibronectin showing bone damage is seen. Caries risk assessment, we all know this from a long time. We've been told that Streptococcus mutans and lactobacillus levels are increased in saliva in a patient who has a lot of caries, and the salivary flow rate is decreased, pH and buffer, but it becomes more acidic saliva that works increases the caries rate. In orthodontics, people have used saliva to measure IL-1 beta and IL-1 beta receptor antagonist, and they've seen that it helps to identify people with root resorption. So patients who have this will show root resorption. So again, you have to identify when exactly does it show up. Does it show up before the root resorption or when it is starting? We need to know that. And in lichen planus, there are a lot of studies done on Salivomics and lichen planus, and they have said these levels are increased. So cortisol levels could be increased because of, yes? Cortisol levels are increased because of probably stress, and inflammatory components are increased. But we don't know whether this is current for patients who are responding to treatment or who do not respond to treatment. So that's another question. So there are a lot of different questions that could be answered by doing some more studies on saliva. So to bring it together, the advantages of Salivomics, as we have already shown, it is safe and easy to obtain samples. Saliva does not clot like blood. It's non-invasive, so patients feel easier to spit, and everybody, as already said, people do spit everywhere, so it's easy to spit, and it's inexpensive, minimal risk of cross-contamination. Those are all the advantages. Disadvantages are levels of certain markers may not be a reliable reflection of these markers in the serum. And it also depends on when it was taken, method of collection, degree of stimulation of the saliva. Is this flow, if it's unstimulated saliva versus stimulated saliva, is there a difference? So those have to be considered when we are studying saliva. And the pH and can affect the concentration of different markers that are present, and proteolytic enzymes can affect the stability of the diagnostic markers. And they do say it is very inexpensive, but when you have to run a test, and the tests are either done on the saliva using liquid chromatography, RT-PCR, or it could be gel and capillary electrophoresis, or it could be nuclear magnetic resonance, mass spectrography, and immunoassays. These are all expensive studies. So it is not very cheap as well, but obtaining the samples is cheaper compared to doing studies on the serum. So Salivomics, in conclusion, it's a promising field of research. There are the studies have shown there are variable designs, study designs, protocols, sampling techniques, and collections, and all these have to be standardized for an accurate and methodology to validate salivary biomarkers. That's why, though there is so much talk about Salivomics, but it is not really in the field of diagnosis and prognosis. So this needs more proper study designs, and probably having multi-center studies having the same design pattern is important. Anyway, we will go to the next part, salivary hypofunction and hyposalivation. So the people use different terms, xerostomia and dry mouth, which means it's a subjective feeling of oral dryness. And this is a very common presentation in your patients. Actually, half my patient pool has salivary hypofunction or hyposalivation. And they have decreased amount of salivary output, and it is less than 0.1 ml per minute of unstimulated saliva and 0.7 ml per minute of stimulated saliva is considered hypofunction and hyposalivation. So it's important to know how to manage salivary hypofunction because it's a common complaint. And it results in a lot of dental problems like increase in caries and candidiasis. I tell my general dental students that they first have to identify patients with dry mouth early enough, because otherwise they may do a very complex treatment plan and cost a lot of money and do all the treatment plan and do all these crowns and implants and everything, and things start failing because caries is still there and they are not managing dry mouth. And candidiasis is another problem, and these patients come in, say they have problem in speech, mastication, swallowing, and denture retention. So it happens at different stages, and it can cause a lot of problems. And I've told you already how saliva helps in protection of the oral cavity and oral mucosa, and less amount of saliva can result in trauma to the soft tissues. The common etiology people think is Sjögren syndrome, because that is probably one of the important causes which affects the salivary glands, resulting in decreased amount of saliva, or head and neck radiation therapy. And it's probably very common. It is common in India because we have a high oral cancer rate in India who are treated with head and neck radiotherapy. And now the radiation therapy is much better compared to when we were students, and it is more targeted and less amount of damage to the salivary glands. But even though it is such, it does result in decreased salivation and taste problems. And though the taste problems are for a short duration, and even acquired immune deficiency syndrome like HIV, people thought that causes decreased salivation, and sometimes that was a big deal. Initially, people would say there is bilateral salivary gland enlargement, that is the parotid gland enlargement, and it is seen even in diabetes, and sometimes people with depression can have parotid enlargement. The most common cause of dry mouth or the salivary hypofunction is medication. So I tell my students that that medications, we have to find somebody to blame any problem in the mouth, then blame the medication, because medications are a good source to be blamed on. And it causes dry mouth, and there are a lot of medications which can result in dry mouth. And there is no one particular study which is done to look at the unstimulated saliva and the stimulated saliva before the patient goes on the medication, and then check the same thing once they are on this medication, tricyclic antidepressants and muscarinic receptor antagonists. There is no one particular study which looks at the saliva, but it has all been implicated that they cause problems, and patients come in taking all these medications. And this was one of my patients who had a big bag full of medications, and she brought the whole list, because I ask every patient to bring their list of medications properly so that I know. And this is one of the patients who had this number of medications, and I don't know whether they are helping her at all, because for bipolar, she's taking so many medications. And are they really working? Somebody has to check on that, but the physicians have no time to go through those medications and say, yeah, you're taking too many of them. So if for bipolar, the woman is taking quite a few, if you can look at the list. So there are a lot of medications, and the list goes on and on. So these are not this is pretty common in my patient pool. So the prevalence of xerostomia in medicated patients have been about 32.1% and 8.4 in 2 population-based studies. So it has been shown that it really does cause a problem. So mouth mirror sticks to the soft tissue, and they will have multiple cervical.
Well, ma'am.
Uh-huh.
Ma'am, I think we may have to go back to slides because we lost your audio there. So if you can start from there, we will have a good connectivity, please. Yes, please.
Okay. I don't know why this is happening. It results in severity and subjectivity of dry mouth can be clinically assessed by the different questions. And Beck et al. In 1961 used these questions to identify the subjective feeling of dry mouth. And you can see how subjective these questions are. So Fox et al. In 1987 have introduced these questions, which are a little bit more objective compared to the questions which are asked before. So here, depending on how they are feeling, depending on difficulty just sipping, if they have to keep sipping liquids to help in swallowing, then it is it's given 1 point. Does your mouth feel dry when eating a meal? Then it is 2 points. Have difficulty swallowing large foods? Then it is 3. And the amount of saliva in your mouth is very little, then it's 4. So these are different questions to ask the feeling of ask about dry mouth. And dry mouth is a difficult question. Sometimes patients come in saying their mouth is dry, but you see enough amount of saliva in the mouth. So how do you differentiate? How do you identify dry mouth properly? Becomes a difficult problem. So these are the different oral findings. I feel when you put your mouth mirror in the patient's mouth to check on anything, it sticks to the soft tissues. That's a very good indicator of dry mouth. And these patients can also come with a lot of cervical caries, which is a good identifying point. And then they can also have candidiasis, and I'll show you certain cases showing candidiasis. And these patients can come in saying they have burning mouth and they have taste problems. So that is probably due to dry mouth. You have to think about dry mouth when patients come in with these particular symptoms. Or they could have some traumatic ulcers and frictional keratosis, irritation, fibromas, because they are biting the areas and causing problems. So how do you manage dry mouth? You can use different mouthwashes which are available over the counter. Here they are called Biotene, Lubricity, Saliva Sure, Salivia, and Act mouthwashes. They also have sprays and gels. Biotene and Salivia have hydrating spray and gel. So these gels and sprays help certain patients. So you can't say which one helps the patient better. We have to tell the patient there are so many things available you can use and check which one works the best for you. And Xylemelts, you can ask some patients use Xylemelts, but sometimes just using ice cubes in the mouth, not biting into them, it's probably good. Keep drinking water the whole day, sips of water. That is a good thing. Fluoride tray, you may have to give fluoride trays with Prevalence 5000. And these patients have to be told that they use the fluoride every day on the tray. And that is important. No point just using to brush the teeth with Prevalence, because they have to use it on the teeth and hold it there for about 10-15 minutes so that it works to cause remineralization of the enamel. So it is important to know how to use the fluoride tray properly. Another important thing is to use the silogogues. That is Saligen, pilocarpine, and Evozac. These are silogogues that are useful. And I use a lot of time patients. I give patients pilocarpine 4% ophthalmic solution. That is 2 drops in food and water 3 times a day. And it doesn't have so much of side effects, because Saligen or the pilocarpine, if you give these patients, they can have a lot of sweating and gastric motility is increased, and it can result in diarrhea. So these patients have to be warned about these side effects and things like that. And pilocarpine works really well if they can use 2 drops in a bottle of water for about 3 hours. You know, they keep sipping the water. Evozac is a good medication too, and it doesn't have a lot of side effects. But the problem is it's a little bit more expensive than pilocarpine. So sometimes it is not covered by their insurance. Here that problem arises. I don't know about giving these medications in India and how expensive they are in India. Another thing that has come in the market now is a 3M xerostomia rinse. That is, again, some patients love it. It comes as a spray, but it is a prescription, and it is from Minnesota. So it is a 3M xerostomia rinse. They have a separate prescribing modality, and you can give them a 3-month supply. You can prescribe 3-month supply, and it works for these patients. And nowadays, there is a new thing that is available, which is called the Salipen. Apparently, I have not used it, but apparently some friends of mine from Indiana have used Salipen, and this is coming from Israel, and you can go to salipen.com and buy it and tell the and give it to the patient, and it costs about $240 US. So they say if you're buying as a dentist, you will get a special deal. I don't know how much, whatever, but apparently it results in electrostimulation and increases the production of saliva, and there is no pain or nothing felt by the patient. So it is apparently good, and this is another thing that patients can use if they can get it. So anyway, just to make a point, I want to use certain cases to show you how we go through the diagnosis and treatment for these patients. And I had a 39-year-old female who came in with a history of dry mouth for 10 years. And she had tried pilocarpine and Salivomics, and she said she cannot use that. And she had a diagnosis of diabetes and was on prednisone. Therefore, she got diabetes, and she has A1C of 6.5, so which is under good control, hypertension, hypothyroid, and she has exercise-induced asthma, vitamin B12 deficiency, stomach issues, hypercholesterol, and rheumatoid arthritis. So the rheumatologist sends me these patients because the patient has so much dry mouth. So you can look at the list of medication, and she has Cymbalta, Lamictal, Cerox, and Xyzal, Flexeril, Percocet, and Tramadol, which are all causing her dry mouth. But she claims she has probably Sjögren syndrome. So these are all the problems, allergies she has, and she's not a smoker, she doesn't drink, and she does not like biotin. So that is our mainstay, biotin and pilocarpine she cannot use. So this was her exam finding, and she has bitten her cheek, and she is a grinder, so you can see the teeth are all ground down, and she has a little bit of plaque accumulation because of the decreased amount of saliva she has. And she has a little bit of ulceration here and candidal infection at the corners, angular cheilitis. So these were the exam findings when I saw her day one. And so I told her, avoid coffee, soda, alcohol-containing mouthwashes, advised to chew Theramint lozenges and sugar-free candy, and I asked her to use the humidifier, and sleeping on your side brings about more salivation at night, so it helps to control a little bit of the dry mouth. And drinking milk with meals is helpful as well. It helps to swallow the food. And I did tell her to use salvia and lubricity because she doesn't like biotin. And I also gave her 4% ophthalmic solution, pilocarpine solution, to use as drops in her saliva or food and water. After a month, she came back and she was a new woman. And she said she loved the pilocarpine, and her angular cheilitis had decreased, and the saliva, there was some moisture in the mouth, and she was feeling better. So this is one way of, and I'm seeing her every year, once a year now, and maintaining her on pilocarpine solution. And it's not much and doesn't have any other side effects. This was a 45-year-old male who came in with a history of lip bleeds and crusty areas, and the lip was not healing and was using a lip balm. He had a diagnosis of Sjögren syndrome and asthma, which was athletically induced again, and arthritis. He was on methotrexate, hydroxychloroquine, meloxicam, and Symbicort. That is the inhaler. And he was allergic to sulfa, and he couldn't remember the reaction because it happened early in his childhood. And he was not a smoker, didn't drink, and he was not using any mouthwashes. So you can see his lip, which is dry and bleeding, crusty areas on the lip. And this was because of his mucinous, thick mucinous saliva, rather than having more moisture in the mouth. It felt very sticky. And so the fissures I showed you. So this patient, we treated him with Vitone cream, which is an anti-fungal idoquinone with cortisone, and that helps to control the candida and the bacterial infection and inflammation because of the corticosteroid. And this was his appearance in a month. So you can see his bleeding has stopped, and now I told him to use the lip balm, which contained lanolin instead of the petrolatum. So lanolin is a better mechanism of maintaining dry, wet or moist lip compared to having petrolatum. Petrolatum dries you up. So this is the patient 1 month later. Then this is a 69-year-old female who came in saying her tongue is hurting and it's very painful. And she has history of panic disorder and depression, hypertension, fibromyalgia, COPD, GERD, and she was on all these medications. And you can see the number of medications that can make her mouth dry. And then this is her appearance. And I call it mother of all candidiasis. So this is a patient who had fungal pseudomembranous candidiasis in a profuse pattern, and every part of the oral cavity was affected, and there was these white cruddy areas which could be wiped off. And you can see there are tongue, a palate. She's an edentulous patient. She had pain, and it started only a couple of days ago. So she fulfills the criteria for diagnosis of pseudomembranous candidiasis. And so I discussed with her about the clinical findings, and asked her to use clotrimazole or Mycilex 10 milligram troches, and then asked her to rinse her mouth with warm salt water after she used the inhalers. And I also asked her to use the biotin. So I think it was a combination of dry mouth with the inhaler which was causing her to have the pseudomembranous candidiasis. This is 3 weeks later after she used the clotrimazole. You can see how the area has healed. And I told her that she could come up and have the same fungal infection if she doesn't use proper rinsing after using the steroid inhalers. So this was a very good case showing candidiasis with dry mouth. This is a 83-year-old male who was taking doxycycline and oxycodone, not many medications, but has bilateral parotid gland enlargement and dry mouth. And he was diagnosed with diabetes and has prostate problems. And his A1C is 7, so it is under good control, but blood sugar that morning was 185, and that could be because he cheated the previous night with some pie or whatever he was eating. So that can result in increase in blood sugar that particular day compared to 7, which shows the hemoglobin A1C is a 3-month window. So it is telling us that he has a pretty good control on his diabetes. But you can see the parotid enlargement, and this particular patient had multiple teeth missing in the anterior, in the maxillary arch. He had all crowns, and they were, he had crowns with decay there, and some root canals were done, and there were some teeth that were pulled initially. So this is the exam finding, and we decided that this man had dry mouth, and we also checked the unstimulated saliva and stimulated saliva at amount of unstimulated and stimulated, and they fell less than 0.1 ml per minute. So we diagnosed him with dry mouth, and we gave him dry mouth instructions and fluoride trace, and that was how we managed this 83-year-old male. So now this 47-year-old male came in with a history of constant dry mouth, and he said saliva is no good. He said, I don't feel good, saliva is not good, and it sits in the mouth and has to constantly clear his mouth. This has been going on for 1.5 to 2 years, and he uses biotin spray and pilocarpine, but has a lot of sweating, taste and smell not good. So everything was not good. The patient was complaining, and he had a bike accident and had brain injury and had seizures, and he was using a hearing aid because right ear he couldn't hear, and he had seizures, and left eye had no peripheral vision. He was getting TMS, that is the transmagnetic stimulation of his brain to improve for his seizures, and he was going to get 36 more. He had hypertension, and he was, with all this, of course, one person will be depressed, and he was depressed. So he was taking these medications which made his mouth very dry, and he was a complainer. But in the mouth, when you see, it doesn't feel very dry, but he was complaining of dry mouth. And then you see, look at his teeth, and there is plaque accumulation. Tongue looks dry. So, he has a very dry mouth, and you can see the amount of plaque that is accumulating on the teeth. And this man, I diagnosed him as medication-induced xerostomia, and we gave him all the instructions, and I stopped the pilocarpine because he was having a lot of sweating. So Salogen, which is 5 milligram tablets, he stopped, but he started taking the ophthalmic solution, and he was using that. He was finishing the 15 ml. Some patients use it for 2 months, but this patient could finish it in 15 days because he was putting a lot of drops into whatever he was eating or drinking. And I told him that, and he was also drinking a lot of soda, so I asked him to stop that as well. So this is his mouth after 3 months. You can see there is some amount of plaque, but it is better than the initial time. So it is helping, but he said he has to constantly use the medication, otherwise it is not helpful. So it was not very easy to manage this patient with all these different problems. This is the next patient, 74-year-old. I just wanted to show you the different problems you can get. And this patient came in with taste problems and dry mouth, and she had lost 50 pounds. So you see how dry mouth can affect patients in different ways. And this patient has problems with taste and was not able to eat properly, and she had lost 50 pounds of weight. And she also has other stomach issues, and she was taking a lot of medications for the stomach problems, and she was allergic to some medications, and she was not an alcoholic or so here you can see she is edentulous, and she couldn't wear her dentures, and she was, when she was wearing the dentures, she had problems in the palate. So you can see the red areas, blotchy red areas on the palate. So I diagnosed her with chronic erythematous type of candidiasis, and the denture was not fitting properly. So I asked her to use, get new dentures, and if she was using the dentures and not treating the dentures, then there was no way we could bring about betterment of candidiasis. So she had to use the some solution, which is the Darkin solution, to help to clean the dentures, and again prescribed clotrimazole 10 milligram troches. How do you prepare the Darkin solution? It's nothing but sodium hypochlorite, which is diluted. So we do not want patients to use Clorox in its entirety, like which comes in big jugs. Here, the household bleach, but use and make it diluted. So you use water These are the things that you need, and we usually give this particular information to our patients so that they can make their own Dawkins solution, and then we tell them how to make it, and they put it in their water. They boil the water, and then we also tell them remove from heat. So every thing is mentioned and how exactly they have to do, and they put half a teaspoon of baking soda and then 24 ml of Clorox into the solution and store it. And then the stored solution, you take it and add 8 ml of water again, dilute it so that you are getting 1:16 amount of dilution, and soak the dentures overnight. So this helps to keep the dentures clean and prevents the transmission of the candida from the denture back to the mouth all the time. So this was following treatment, and you can see there is a little improvement in the appearance in the palate, but still this patient needs a new denture because the denture is ill-fitting, so it is adding to the trauma and causing problems as well. So there is areas of redness have decreased comparatively. So this is the different things that could happen with salivary hypofunction. Now, salivary hypofunction, not many people will come with this particular problem, but it's called sialuria, drooling. Usually patients have cerebral palsy or mental retardation, or they could have a stroke, they could have problems swallowing. That's why they are having more saliva, because you are swallowing saliva every time, every minute, though you're not doing it knowingly. It is happening every time. So people with strokes can have a salivary hyperfunction, and sometimes patients with Parkinson's and amyotrophic lateral sclerosis, sometimes certain medications can cause salivary hyperfunction, but these are not many as compared to hypofunction medication. I had a patient, the very few patients I've had with sialuria. I've had about 3 or 4 patients in my 15 years of seeing patients in the dental school here. So this patient came in saying he is drooling, and his lower lip appears to be prominent for the past 3 years. He cannot talk. Eating is otherwise okay, but he cannot talk because he has a lot of drooling. And he was treated for prostate cancer with radiation and chemotherapy, and he has tremors on and off. So I thought this particular patient was taking all these medications, and he had quit smoking in 1972 and had smoked 8 to 10 years, 2 packs a day. And he was using Equate as a mouthwash. And the unstimulated saliva was 2 ml per minute. For 5 minutes. So I always try to collect saliva for 5 minutes so that we see at least we know what exactly is the amount of saliva that they are producing. And he had more plaque, and he had some missing teeth. And so here the problem he has is sialuria. But I gave him propantholene, which helps to control the amount of saliva, and asked him to take it twice a day. And he said that it helped, but I had also told him that he needs to go in and see the neurologist, because I was suspecting that this guy could be having Parkinson, because he had certain tremors on his hands and things like that. So I was thinking whether the patient had Parkinson. but he went to his physician and they said he didn't have any signs of Parkinson's. So now he is undergoing problem, checking out whether he has problems swallowing, and by an ENT. So that's where we are at this moment on this patient. So it's good. Saliva, if there is increased amount of saliva, could be due to certain diseases, or it could be swallowing problems, and you need to identify that. So in conclusion, I just want to tell you that saliva is, as we have discussed, have shown that it is a complex entity, and it is indispensable to the oral and general health. And Salivomics, I showed you certain studies where they have done biomarkers and showed there is increase or decrease, but they need to be validated. There is more work that needs to be done, and more work needs to be done on pre-malignant lesions compared to oral squamous cell carcinoma, because we want to identify this disease before the patient has a major squamous cell carcinoma needing a lot of surgery and things like that. Dry mouth is a common condition, and it is very difficult to manage these particular patients, but you have to start with over-the-counter and use the xylogogues effectively, and that's important. Sialorrhea is not very common, but be able to diagnose and manage and refer these patients properly when suitable, when necessary. Any questions? Thank you.
Thank you so much, madam. It was a wonderful talk, and this reflects your in-depth knowledge. For those who would like to connect with her for further research and clinical work, ma'am is the Associate Professor in Department of Oral Biology, University Dental Associates, which is in Nebraska, USA. Ma'am is also a BDS graduate from Government Dental College, Bangalore, MDS in Oral Pathology from College of Dental Sciences, Kastubaraba Medical College, Manipal. She's also done her MS in Oral Biology from University of Missouri, Kansas City, and DMD in Dentistry from Temple University School of Dentistry. So her teaching responsibilities also include advanced oral pathology. She's being the course instructor of advanced oral pathology, integrated general and oral pathology. She's the course director of clinical oral pathology, general pathology, oral pathology, and oral medicine. And her research area or interests include the field of oral cancer and lichen plants. She has numerous publications to its credit, and thank you so much, ma'am, from the bottom of our heart for accepting our invitation. We are honored to have you here, and if you would permit, we would like to ask, the participants would like to ask you some questions.
Yes, please. Thank you so much for giving me the opportunity to share some information. And I'm not a world's expert on any of this. So I'm still a student every day. We don't know a lot of things.
Thank you so much, ma'am. We always need to be students. That's how we always progress. I would like to ask a few questions. Does xerostomia lead to loss of taste sensation?
Right. It does lead to loss of taste sensation because the saliva helps in moving the contents in the mouth towards the taste buds. It helps in receptors are brought together with the food products which have different taste. So they help in bringing them together. So that is why patients with Sjögren's syndrome or patients with dry mouth have taste problems.
The next question is, can salivary flow rate and quantity be altered by TENS? Transelectrical nerve stimulation. Can it be altered?
I didn't get the question. Can you repeat the question?
Can the salivary flow rate and quantity of the saliva be altered by TENS?
Yeah, it can be. It depends on what exactly test you're using. And there was one question in here which says, how do you measure salivary flow? So it's a good question. So basically what you do is, it depends. It has to be measured. If you're doing a study, it has to be measured at the same time for every patient, every time. But here in the clinic, what we do is when they come in, we ask them whether they've eaten anything for the past hour. So if they have not eaten anything and they will be sitting, they will sit on the side of the chair and put their head down and spit into a cup. And that is unstimulated saliva. They're just holding their mouth and over the cup. And you're collecting saliva for 5 minutes. And then we measure that. For the stimulated saliva, there is a way of doing that. Either giving them some kind of a beeswax or something to chew on, and then they stimulate the parotid and the submandibular major glands, and they are spitting into the cup. There is another way of doing it, is when the patient comes in, make sure before they come in, you ask whether they are allergic to any of the pilocarpine. If they say they are not allergic to pilocarpine, or they have no lung problems and no other glaucoma, open angle glaucoma, then these patients are given pilocarpine 5 milligram tablets when they come in, as soon as they come in. And then by the time you do your health history and do the unstimulated saliva, the amount of pilocarpine will kick in and they will produce stimulated saliva. So you can collect by stimulating with the pilocarpine, or by asking them to chew on wax or chew on some gum, which has no other agents, which are probably people don't like it.
Okay. The next question is, can saliva be used as a sample to estimate biomarkers to distinguish between reversible and irreversible pulpitis?
But
can you use saliva to distinguish between reversible and irreversible pulpitis?
Yeah, that's a good question. They have not done that. Maybe that's another study to do. There are a lot of studies we can do, and probably you have to have a proper method of collection of saliva and go through this in a very uniform pattern. Okay. And you can check for the inflammatory markers. Probably.
How do you distinguish or differentiate Sjögren syndromes from xerostomia? Apart from history, what else can be done to distinguish Sjögren's and xerostomia?
That's a good question. And the thing is, you will check the medical history, and if they have had SSB or SSA levels checked. Sometimes Sjögren syndrome may not show those things, because Sjögren syndrome is a very complex diagnosis. It is like a solar eclipse. Everything has to come together. It doesn't come together sometimes. So we have to Sometimes we do a biopsy too and check the number of, you count the number of lymphocytes in 4 square millimeter area. It has to be greater than 50 ml, 50 in number in that 4 square millimeter area. There should be 4 foci that you have to count. And when I get those biopsies, I cringe because I have to count. I'm a lazy bum.
Okay. What is the diagnostic value of salivary glucose in type 2 diabetes? Is the value comparable with blood glucose?
I don't know. The studies didn't show that very clearly. Maybe that's another study to do. There are a lot of studies you can do. And actually, there are studies coming from India. Probably you have better way of doing it because you have more money probably. We have no money here. And we have to teach so many classes. And we are only 1 or 2 of us in the department to teach all these classes. So probably it would be better to be in India to teach all these, only 1 class, and then do more research.
Is there any specific role of saliva in post-surgical wound or oral wound healing following biopsies?
What exactly do they want to check? You know, because you can look at the wound and see whether it is healing or not. If it's not healing.
Does the saliva influence the wound healing?
Yes, it does. Okay. It does. It helps to bring the, it coats the surface with mucin, and it helps to, helps wound healing.
Okay. And how many days can we store a sample of saliva before it can be tested?
They say if you're mailing it, it has to be done in 48 hours. So once you get it, you can put it in your cooler at 80 degrees, to keep it frozen. So you can freeze it and use it whenever you want. But you need to freeze it within 48 hours.
Okay. Can you please explain the role or the level of salivary cytokines in oral lichen plants? What will be the level or the role of?
They have shown that it has changed and it is increased. I think it may be because of the inflammatory, it's an inflammatory sign, but really the exact role is not known. That's everybody's question. What is lichen planus, you know? If I knew that, I would be making a lot of money.
Okay. Now there are 2 questions which I'll combine and I'll ask. How is stimulated and unstimulated saliva different? And what is the difference in the pH and the buffering capacity of the 2?
I think unstimulated saliva is more neutral compared to stimulated saliva. Stimulated saliva will depend on how exactly it was stimulated and what brought it on as well. And then the flow, you asked about the flow rate?
Yes, ma'am. pH,
flow rate is higher for stimulated compared to unstimulated saliva. The other things, you have to do studies to identify the difference between them. Okay. Unstimulated doesn't, it's normal saliva. How much amount of saliva is saliva? How much of it is from the gingival crevicular fluid? How much is it from desquamated cells? Because they say cells desquamate every 3 hours. So how much amount is made up. You know, the whole saliva is made up of a lot of things. So stimulated is different in the pH, probably depending on what you're eating.
Okay. The next question is regarding pilocarpine. There are two questions. Any medication taken for systemic condition which can possibly interact with pilocarpine, and how much should we prescribe pilocarpine ophthalmic solution? That is for how long and how many times, and what are the instructions we need to give it to the patient?
So pilocarpine ophthalmic solution is available as 15 ml solution. So you can get 15 mLs, and they have to use it as drops, a couple of drops, 2 drops in food or water, whatever they are eating. If they're eating idlis in the morning, they put 2 drops in their idli and then eat it, or in their coffee, 2 drops in their coffee, and then that will be fine. And put 2 drops in the water bottle and keep sipping the bottle, keep sipping the water the whole time. And then you can use another 2 drops at night. Usually that keeps the dry mouth under control, but some patients may need more than these 3 times. So this depends how long. I think we have to kind of do it for a long time until the dry mouth is feeling better and things like that.
That's a indication that many people are really interested and wanting to connect to you. And it's been such a wonderful session, and more so, I applaud your patience with which you are really taking and answering all the questions. So I think it's
most
time.
Of the questions I have no answers to.
No, that goes, with what you said, that there is a lot of work that needs to be done in this field. And also, if you are okay with it, you can share your email ID with our participants here, because many people are wanting to connect to you, and there are a lot of gray areas as well.
Yeah, you can share my email address with everybody. You know my email, nnarayana@unmc.edu. So, that's a good way to connect with me.
They can
Thank you so much. You have been. Yes, sir, please.
Questions to her.
Yes, sir. So thank you so much, ma'am. You have been, kind enough and generous enough to share your email ID. And I'm sure all the participants would have noted that. And with this, I expect a lot of mails to be coming over to you for, taking your research further, as well as helping a lot of young people's research in India as well.
Can I just add something, Prashant?
Please, sir.
I think this is the first time I've sat for 2 hours, without moving. That's a compliment to you, ma'am.
I didn't do anything. I was just telling you how much I don't know.
I'm a very impatient person. I don't sit through like this, but I think there's only one word which can describe this: mesmerizing.
A lot of ideas though. You have opened our gateway of thoughts to, answer a lot of gray areas in this field.
Probably it's easier to do more work in India compared to here, because we in the universities are short-staffed and we have so much teaching to do, and we are only 1 or 2 people here. So it becomes very difficult. I didn't write up for this. I didn't come here to do that, but I'm stuck now.
So good opportunity to collaborate with you. With that, I think our host takes it over. Dr. Priyanka, please proceed.
Thank you, Prashant. Thank you, ma'am, for the wonderful talk. It's been a pleasure, and there are numerous other questions coming up. Hopefully, since you're willing to share your mail ID, we'll make sure that the participant receive it and they can contact you directly. With this, I would like to request Dr. Usha Hegde to propose the vote of thanks.
Thank you, Priyanka. Thank you, Priyanka. With pranams to His Holiness on behalf of Jesus Dental College and Hospital, I thank you wholeheartedly, ma'am, for engaging us so completely. This evening has been very fruitful for us. Thank you so much. And today's learning on diverse aspects of saliva is, I should say, it's diversonomics on saliva, going with salivonomics. And I particularly liked one of your statements at the outset when you said saliva does not clot, among many other things that you have covered today. That was a really nice statement that you made. Thank you very much once again, ma'am. Ma'am, and if you don't mind, we would like to have more webinars with you in future and continue the learning process.
Anytime. It is my pleasure. Thank you.
Thank you, ma'am. My sincere thanks to our principal, Dr. Ravindra sir, for initiating and encouraging us to take this forward. Thank you, sir. Our academy, JSSAHER, has always been a backbone, supportive in all our endeavors. Our sincere gratitude to JSSAHER and especially to our beloved sir, Dr. Kushalappa. And ma'am, you have to believe him when he said that he sat still for 2 hours. I know, sir, for the past 20 years, and I know how he cannot sit at a place. He's always on the move. So you've really done wonders today. Thank you, Kushalappa, sir. My humblest thanks to Dr. Prashant, Dr. Sumukh, Dr. Priyanka, Dr. Jaishankar, and everyone who have helped us in making today's webinar possible. I'm sure all the participants have had good learning, and thanks to all of you. I would like to note that there were 351 participants today for today's learning process. Wishing everyone here in India a good evening and a good day to others from outside of India who have just started the day. Thank you once again. Over to you, Priyanka.
Thank you.
Thank you, Nagamani ma'am, for the wonderful presentation once again. I thank all the participants for the patient listening, because we had some glitches in the beginning, and even though with everything, it's been a complete package. Thank you so much, ma'am. Hopefully we'll collaborate with you in the near future.
You probably set a record with the number of participants.
Thank you, Kushalappa sir, Ravindra sir, Prashant.
Thank you. Thank you, madam.
A special note of thanks to Dr. Patan Shetty, sir. He was instrumental in getting this into, getting going with the connectivity between JSSAHER as well as madam.
Hey, he is my good friend.
Thank you once again.
So with that, I request our technological champ, Dr. Sumukh, please end the meeting and let's wind up for the day.